testicular tumours is a problem of the young, fit man. It's a 20-year-old tumour, and it's rare. It's not that common. 6 in 100,000 is the highest prevalence or incidence in the world, and that's in Denmark. But once you get this, it's quite a devastating abnormality psychologically for the man as well, though the cure rate is pretty high. And all of you are familiar that there are germ cell tumours and non-germ cell tumours, and the whole sort of gamut of histology that's around at the moment. But bearing in mind that these can be all different types of tumours, with the choriocarcinoma being the more, and embryonal carcinoma being the more difficult ones to treat. Seminoma, almost 100% cure now. But when you're looking with ultrasound, there can be a whole range of appearances of these tumours, and you need to be able to tell which is the abnormal, which is the malignant lesion, as in this sort of patient, from this patient, which is not a malignant lesion, and this one, which is not a malignant lesion, because very often the surgeons, the urologists say, well, you've got two, we'll take one out, it doesn't matter. Well, we want to avoid that if you've got benign disease. And easy enough when the tumours are this size and look quite horrendous. But this is what you're faced off with. You're doing a testicular ultrasound for no apparent, no real reason, like lump or not, ache or something like this, and you come across these lesions, the incidental lesions. Some of these are a little bit more easier to diagnose. Some are very difficult. How are you going to manage these patients? Have they got a tumour or not? Can you leave it? Can you review it later on? Well, ultrasound, we know, is the best way of imaging the scrotum. It gives you really good resolution of the testes and paratesticular spaces, and combination of B-mode, colour, spectral, etc. just makes it much easier. But there's still the diagnostic challenge of that indeterminate lesion. Now, will contrast improve this interpretation, and will you increase your confidence more than anything else? And all these incidental lesions that you find, people have looked at this and looked at what they are, and the highest incidence of these incidental lesions are benign. Even though the numbers here are small, most are going to be benign, but the anxiety they induce in the patient is high. So you want to actually be able to say, leave that lesion alone. We know ultrasound is operator dependent, wide spectrum lesions. Are you going to go on to MR? Well, it's like using a sledgehammer to crack a nut, to make a pun there. But it's high cost, the resolution is not so good, and there are no large studies looking at the cell type, etc. So what happens? These patients have a surgical exploration, maybe a frozen section, they may have an orchidectomy. You want to avoid all of this. So what are you looking at? Well, you're looking at, first of all, the texture and the morphology of the lesion, but you're also looking at the vascularity. Now, the claims are that there's increased vascularity in intratesticular tumours only if they're greater than 2 centimetres. And this paper is now 20 years old, and there's been no further studies looking at ultrasound of the actual intratesticular tumours and how small you can get before you pick up vascularity. And the hallmark is increased vascularity in tumours, and that's what you're looking for. But I think, and we've shown in recent publications, that you can see vascularity down to 2 or 3 millimetres in these tumours. But the bottom line is, if there's no vascularity in the lesion, it's going to probably be nearly always benign. So how do we do our ultrasound of the scrotum? It's not that easy to do. The physics of the microbubbles, etc., lend itself to being best imaged at the abdominal frequencies, the 3, 4, 5 megahertz. So you're using a higher frequency probe. We're using 9 and 10 megahertz here. We inject more contrast than we would do normally in a bolus of 4.8 mils rather than 2.4 or 1.2. And we're not looking at anything but the arterialization of the lesion and the testes, and just watching it drain out. It's quite a nice technique to use, particularly when that testis is inflamed for any reason, and then you're going to get very good enhancement in the testes. And if I just show you this patient with epididymal orchitis, you can just see how vascularized the epididymis is. Now, what about tumours? Well, all sorts of tumours that you will see, things like the germ cell tumours of mixed type, and you're looking at this sort of vascularity in the tumors. We call this the crisscross sign, where you should normally, in normal vascularity in the testes, have linear radiating vessels coming in from the periphery. But in the malignancies, you've got these crisscross sign. And this is what it would look like in a seminoma with contrast enhancement. You get that little bit of rim enhancement around the edge and that all abnormal vascularity through it. And in our experience, we find that the vascularity comes in very rapidly and goes out just as rapidly. So you've only got a period of about 30 or 40 seconds to look at the vascularity of these tumors, but it does pick up these areas of irregularity and problems with the morphology. Lymphoma is another tumor of the older patient, and again, these have different B-mode characteristics and may involve the epididymis. And again, they're highly vascular, but the pattern of vascularity in the lymphomas appears to be different. The vessels are less disordered, and they don't vascularize as much as the seminomas that we see. Then you have the benign, or almost all benign. 9 out of 10 of the Leydig cell tumors, the connective tissue tumors, are benign. And these tend to be more vascular than the normal germ cell tumors. And this is a very small 5 millimeter tumor at the upper aspect of the testes, incidentally found, very vascular. You would think about having to take this out without any further imaging. But these tumors tend to vascularize very quickly on the ultrasound examination, and you can pick up an area of vascular there. Now, what would be important here is that if you were looking at this tumor, the incidental tumor, it didn't vascularize. Leydig cell or a cell tumor. It's looking at tumors with no vascularity at all. And this is an epidermoid cyst, almost classical on the B-mode appearances, but you want to be sure. You can't send this 17-year-old patient home without being absolutely sure that's what you're looking at, particularly if his father is a consultant radiologist and he's in the room, and his uncle is a consultant urologist and he's in the room. You got no chance. So you've got to make sure you know what you're doing, and there's absolutely no vascularity in that area. You know it's going to be a benign abnormality, and you can watch and wait and elect not to immediately take the patient to surgery. And the same with other benign diseases. Orchitis can be a real problem in the testes. It can go to all sorts of bizarre abnormalities with focal areas of infarction. But importantly, sometimes it can give you this appearance of a focal mass. Now, that focal mass in the top aspect of the testes is probably not a malignant tumor, because I did mention to you earlier on about the crisscross irregular vessels, and look how linear those vessels are. And this is confirmed on your ultrasound examination of being uniformly enhancing and linear as the rest of the testes. And this is a focal area of orchitis. You can sit and wait on that rather than taking the patient out. The other entity that is rarer is segmental testicular infarction, occurring in the older patient, not the young boy with the heavy testes and twisting, and these can give you quite bizarre appearances. And it may be difficult for the operator to be absolutely sure there's no vascularity on there. Is it movement artifact you're looking at in causing vascularity, or is this an area of avascularity that you can sit and wait and watch? Well, again, contrast, and this is showing you just that area at the very top aspect of the testes, which is not enhancing at all. And this is an area of focal segmental infarction, and you can afford to sit and wait. This is a patient who had a hernia repair and has had injury following that hernia repair. Other more bizarre-looking areas of abnormality that may be segmental infarction, need not be wedge-shaped, it can be round, and this again shows you no vascularity in that area and an area of infarction. And we've recently published on this particular aspect, looking at segmental infarctions, and we've seen that it's quite a simple and easy technique to use, and just makes you so much more confident that you're dealing with an area of no vascularity in it. You've got a segmental infarction, But remember, these lesions are not common, they're quite rare. Another entity that you may not be familiar with, if you've got severe epididymal orchitis, you can have so much edema and swelling, etc., that you occlude the veins. You compress the veins before the artery, and you get venous infarction of the testes. And you get this sort of bizarre appearance in the testes. And injecting contrast, you can see that this bizarre appearance that you're not sure what's going on there is actually an area of infarction, an irregular border, making it more venous-like, rounded, making it more likely to venous than the arterial wedge-shaped infarction. And you may get some very indeterminate-looking lesions like this, which when you inject contrast have no vascularity at all. It's probably a venous infarction, but you can't be absolutely sure that you're not dealing with an abscess within the testes, but less likely, because I want you to look at the surrounding enhancement of there. There's no increase in enhancement as you would expect in an abscess. And again, Bertolotto's groups just published a paper looking at acute scrotal diseases, and their conclusion is that it's a useful tool, and as I brought to you all over the course of the lecture, it's a useful tool to indicate there's no vascularity. And this is a total infarction of the testes. In severe epididymal orchitis, the epididymis is still inflamed with two small abscesses in the epididymis. So very useful there from that image to know that you've got a dead testes and there's nothing very much you can do. This is that abscess within the testes. You may actually think, well, yes, I know that's an abscess. There's debris in there. There's increased vascularity around the side. But you're much more confident there's nothing going on in there, and there's enhancement all around that focal testicular abnormality. But it's the presence of, not so much the presence of increased vascularity that's a concern. It's the absence of vascularity in any focal lesion that tells you that this is likely to be benign. This is a small, as we were saying before, small Leydig cell tumor, 10% of which are malignant. They will probably go, based on these appearances, probably do a frozen section and a partial orchidectomy, because the patient's not at risk from developing any other tumor, as opposed to a total orchidectomy if this was a seminoma. But I know that this is an area of testicular biopsy, because we watched this and we had a clinical history, but it just shows you that how bizarre these appearances can be and how there is no vascularity in there to help you. So just a flow diagram to emphasize what I've said. No vascularity benign, vascularity seen, vascular pattern looking normal and linear. Think of orchitis, anything disordered, think of malignancy. But there's more to it now. We have elastography as well that's coming through. So if you've got a machine that can do contrast and elastography as well, well, have a look and see how hard that area is. This is a small seminoma, and the elastography here is 3 times that of normal testes, measuring at the same level as the lesion. And these are 2 seminomas with elastography strain ratios measured over at 4, so it's much harder than normal testes. And this may even take you even further into the future, looking at focal testicular abnormalities, a Leydig cell tumor and a seminoma. How is it different? Well, the Leydig cell tumors are much more vascular on Doppler than the seminomas. They enhance very avidly and remain enhanced for much longer than a seminoma, which doesn't enhance as much. And also on elastography, they don't appear to be as hard as those vascular tumors. Don't take this home and say, this is what it is now, this is the law. This may happen. We don't know yet. I can only show you a few isolated cases, but maybe you're going to be able to do more than you can at the moment with those focal indeterminate lesions. And this means other house. Thank you very much.